what happened to Azavan?
Yes, so I can talk about Azavan. I'm a consultant for them, so that is my disclosure. And I've received consultant payments and also salary support at Georgetown from Azavan. They are planning a phase 3. They're currently in the process of looking for a larger company to sponsor them for the phase 3, but Azavan does plan to bring back their drug. This was a vasopressin antagonist. So a very cool drug because it works on the brain separate from HD. So it's not specific to HD. It works on the parts of the brain that cause people to have rage and irritability and actually fear also, to calm those things down. And in the phase 2, we found that it was effective in calming down those types of responses without making somebody sedated and overly medicated. So we're working really hard to get a phase 3 launched.
Okay, fantastic. We didn't hear about it for COVID, and we were like, I just thought, what happened? That's great. So hopefully we will see a trial soon.
Yes.
Our next question is for Dr. Anderson. My son was in the service. During that time, he was in active war. He also did a lot of drugs and alcohol during that time. Would that have exacerbated his symptoms?
So first off, thank you to your son for his service, particularly serving as an active combat vet. And thank you to your family for sending him in harm's way to defend his country like this. It's a huge thing that he's done, really important. I don't think, in my experience, and I've worked with quite a few people with HD who have been in the service, I don't know that we can say that it exacerbates the disease. It may cause certain symptoms of the disease to seem like they show up a bit earlier. So particularly if somebody had heavy drug use, that maybe makes them more disinhibited, so make them more likely to act on symptoms, particularly if they continue to use drugs after they're discharged from the service. Certainly if he was in active combat, I would wonder whether he has post-traumatic stress disorder and whether he's reliving combat experiences or dreaming about them or finding that they're intruding in his thoughts when he wants to do other things. And that could contribute to big mood swings or rage. So sometimes it does seem like a big event like that, like being in active combat, being in dangerous situations, or stressful situations. Sometimes it does seem like it brings out mood swings and irritability a bit earlier. But it's hard to know because we don't have sort of a parallel experience where your son didn't serve and then developed HD symptoms at the same age or not. So that's why it's hard to know.
I'd like to ask a question kind of on the flip side of that. If somebody who is, say, pre-symptomatic and is using drugs for quite a while, and they do end up having HD, I don't even know how that would work, but do drugs ever mask HD symptoms? Or have you seen someone get sober and then their HD symptoms present themselves?
So do drugs mask HD symptoms? Yes, it can be really hard if somebody's actively using drugs to know if their memory and concentration problems and their depression and anxiety and their sleep disturbance is all early HD or if it is related to the drugs. So sometimes when people get sober, then we're able to sort it out and we're able to say, you've been off drugs, you've been sober and clean for a year, and you still have all these memory and concentration problems and you're still having mood swings. So it's likely that this is HD. Maybe it was HD underneath it and you were self-medicating. So unfortunately that does happen when people have horrible anxiety, horrible depression, and they self-medicate with drugs because that's the only thing they can find, street drugs, to help them with those kind of conditions. And I do tell people with HD, if they're actively abusing drugs and alcohol, that these substances damage your brain when you use them in excess. And anything you do to damage your brain is going to set you back more as your HD starts to progress. Living a healthy life, not doing crazy things or extreme things, you're probably going to be in a better spot once you do get your HD.
Thank you so much. And I think if you guys are willing to stay on with us, I know we did the submitted questions, but we have a couple of questions we wanted to ask if you guys are willing to answer. And then there is a couple questions that came in through the streams. If we can bring those up, if you guys are willing to stay on with us, that would be awesome. They're like, we're not going to say no. You just put us on the spot.
We have things to do. So the first question, the FDA mentioned that they see flaws in our diagnostic criteria, and they hear patients want to be tested earlier. Do you see, with new therapies and treatments on the horizon, that the current diagnostic criteria would actually harm people from getting access to therapies that have been stated, if approved, the earlier intervention, the better? Do you think healthcare providers, once a therapy is approved, will move away from the criteria to get their patients access to life-saving therapies and quality of life treatments fast than what is currently allowed?
Yeah, so a few questions in there, and I think the answer to the last question is yes, I would hope so. But this is a hot topic. It's something that the diagnostic criteria in HD, and when do we actually make a diagnosis? We know that individuals are born with the mutation, but we know there's a period in which individuals are asymptomatic. And then we know that when changes start to occur, that it's not as if we go from one day to the next, asymptomatic to symptomatic, that it's a continuum, and that the changes that occur slowly, and there can be changes in there can be psychiatric symptoms and subtle changes in thinking and subtle changes in coordination and movement, but not significant enough to warrant a clinical diagnosis. We know that the diagnosis has historically been based on the motor symptoms, the chorea, but we all know that HD is much more than just a motor disorder, that the non-motor symptoms, or the symptoms that we can't necessarily see, can really be important when thinking about quality of life and functional independence. So the clinical diagnostic criteria, definitely a work in progress. And I know there are efforts underway to try to modify the clinical diagnostic criteria to potentially provide a diagnosis earlier when it's necessary, because we often see, I'm sure Dr. Anderson will agree, by the time patients come to see us in clinic, there's been a ton of collateral damage due to often the non-motor symptoms, the psychiatric and cognitive symptoms. And they've been told, no, you don't have HD because you don't have chorea. And again, there's a lot of collateral damage that's occurred. So we need to think about and talk about potentially making that diagnosis earlier. Now, when it comes to research, that's a similar but different story. And in fact, I think we've made more progress in the realm of research in making a diagnosis, if you will, than we have clinically. And there are pros and cons to this whole story, and I could ramble definitely, which I'll try not to do, because I know Dr. Anderson has some pearls of wisdom as well. But I want to mention something called the HDISS, and this stands for the Huntington's Disease Integrated Staging Scale. And this is a really big deal. This is something that was published not too long ago, and you can find it online. This is a document that was published, and it was a result of multiple really bright, wonderful individuals that are invested in HD and trying to help us determine when we should intervene in various clinical trials, clinical trial compounds. We have the advantage, if you will, in HD. We know, as I said already, we know the causative gene, and we can't say that for many other more common neurodegenerative diseases like Parkinson's and Alzheimer's. We know, as I said earlier, that there's a kind of what we call a prodromal period. There's a period where things are changing in the brain. There's some neurodegeneration that's occurring, but it's subtle, it's mild. But can we take advantage of knowing the causative gene, knowing that individuals are gene positive, and trying to intervene with a disease modifying therapy that we don't yet have, but we're of course optimistic about the future? And can we intervene earlier rather than later? That's really the question. And that's what all of the authors of this HDIS tried to answer. Should we intervene earlier with clinical research? And so they took advantage of many of the data from many of the prospective clinical trials that have been done. And thank you to all the individuals that participated in these studies and that continue to participate in studies like Enroll HD and others that have been done along the way, to help us learn more about what's happening actually in the brain structurally, and what's happening throughout the body in that prodromal, that really early period, and how can we define that so that we can effectively intervene with these disease modifying therapies that are being studied earlier rather than later. So I don't know that I absolutely answered the question, but I would say, again, it's a great question, and we're looking at modifying the diagnostic criteria clinically, but then we've already made great progress in the research realm. And so, Dr. Anderson, you probably want to elaborate on that as well.
That was a perfect answer. I only have a couple things to add, really. So going back to the question we had toward the beginning from the individual who said, I have 44 repeats, but I'm not symptomatic and I want to be in trials. I've done observational. I think it really shows the value of observational studies. So sometimes they're not as flashy and sexy and people feel like, why am I doing this? Why am I coming in every year and doing all these measures and tests and things? Why am I getting a spinal tap? I'm not getting a drug. But the ISS scale was the result of all of this observational information that we had on so many people who kept coming in year after year and contributing information. So for those of you who are on the fence about whether or not it's worth these trials, absolutely, because that's what's moving us into earlier stages or even pre-symptomatic studies. So that's one thing. Another is, I think Dr. Furstemming did a really good job separating clinical diagnosis from research. So for clinical diagnosis, some of it I think is, when do you as a patient want to be diagnosed? If there's nothing currently that will slow your disease progression, maybe you don't want to be diagnosed at this time because you feel there's nothing it does for you besides bring you down, right? But if there's a drug available, which we hope we'll have soon, that could slow down your disease progression, people may want a diagnosis earlier. So I think that's a conversation that we're going to have more and more in clinic as we get closer to having one of these treatments, that getting diagnosed earlier based on really subtle symptoms and signs of HD might be to your advantage then. And I think part of the question was, will doctors get these therapies to patients? There are really subtle things that we can see on exam that your general practitioner might not pick up. But for those of us who see a lot of HD patients, we could make a diagnosis based on those, if that's what it would take to get you into a treatment trial, or if it would get you an approved drug once we have one of those. So I think that's another way to think about it. The clinical trial criteria are different, right? So having clinical diagnosis is one thing, getting into a clinical trial is different. And I think we have to remember to keep those really separate.
Yeah.
So a message just came in on this topic. It says, how do we, as pre-symptomatic and prodromal individuals, work with professionals like you all to get the clinical diagnostic criteria updated?
I think the advocacy is really important, getting in front of whomever you can. If there, I know HDSA has done quite a bit of advocacy, so getting involved in any way that you can, and doing these studies, coming in and doing the observational studies, so that when we go to agencies like the FDA or the European Drug Association, the EMA, we can say to them, look, we have all this information on pre-symptomatic individuals. There are changes that happen. It may not be Korea, it may not be the standard way we diagnose HD, but the changes are there. And this is something that we can address in our clinical trials.
Yeah, and it was really interesting. So on our FDA, our FDA patient listening session we had on February 10th, Billy Dunn was on there, which was really exciting. And he was talking to us, and it was interesting because as we were preparing for this meeting for 8 months, they said, don't talk about things that we can't control. So stuff like diagnosis and insurance, right? Paying for drugs. We can't control that stuff. So let's focus on what the FDA can control. And so we did this, and we took out the whole diagnosing and diagnostic criteria. We took it off the plate. And then Billy Dunn was the one that brought it up during our Q&A. He said, it seems like you guys are have a lot of trouble with diagnosing HD. What's going on? He was basically asking us, and we were like, we weren't expecting that question, but he really sees the FDA does see a problem with the diagnostic criteria from what they're hearing. I don't know if they're hearing it from sponsors. I don't know where they're getting it from, but they definitely have a heightened awareness on HD diagnostic criteria, and they think it could be better, is what they were getting.
That's great that they're getting the message.
Yeah, completely
That's
agree.
good.
Yeah, and there's room for improvement. I do want to mention though, and this is probably obvious to everyone, a gene getting tested, obviously that's a really big deal in moving forward with genetic testing, but a positive gene test, it does not equal a clinical diagnosis. And so, as I mentioned, and as I'm sure everyone listening knows, you can have a positive gene test, but be really, for the most part, asymptomatic. And it's really important that folks know that just because they test positive doesn't mean that they have a clinical diagnosis.
Thank you. And then another question that was brought up at the FDA, and I know this is very futuristic thinking, that hopefully these we have a disease modifying therapy available eventually. But at the FDA meeting, there was talk about prenatal screening. They brought it up. And do you see, if we have therapies available in the future, that our community would start moving towards having prenatal screening done? Of course, this is if we have a therapy available. And can you give us a clearer explanation of what prenatal screening is and what it would look like for a family impacted by HD?
It's a really good question. I'm waiting for Dr. Anderson to answer.
I was waiting for you.
Okay, so first things first, let's say when we have a disease modifying therapy, not if, when we have a disease modifying therapy, and stay positive and optimistic, although it's research is, we're, despite the great research underway, there's still so much work to be done, and it's not fast enough for any of our patients and families with HD or at risk for HD. But when we have an effective disease modifying therapy, then I think it would be absolutely, as we've talked in with our discussion about making a clinical diagnosis earlier, it makes sense to have that gene testing done earlier if you are potentially eligible for a therapy that could slow or halt disease progression, because it just makes sense that earlier intervention is probably better than later. And so the prenatal testing question is a great one, but that's talking about really early intervention. And I think that answer is complicated, but I think that it certainly will be a discussion that we will have as a community and trying to decide whether or not it's appropriate to actually perform prenatal testing. And I think folks would at this point say, no, we're not there yet. We're not comfortable with that. But if and when there's a therapy available, I think it's something that we as a community could absolutely consider and talk through the potential benefits and of course the potential risks.
So in terms of what prenatal screening is, you could do, or you can do right now, chorionic villus sampling, which is called CVS, which you can do at 12 weeks, or amniocentesis, which you can do at about 16 weeks. Usually those are done now because somebody is pregnant and wants to know whether or not the child is going to have the HD gene expansion, and they may use that information to make a decision about terminating a pregnancy if the child carries the HD gene expansion. So that is the prenatal screening that we have. There's a risk in doing both of those procedures, right? There's a risk of miscarriage, which is very small, especially at very experienced centers, but there is a risk of undergoing those procedures. I think the philosophical question that we grapple with is prenatal testing means that you're making a decision about about knowing the child's gene status without the child being involved. So you're taking away that individual's right to choose whether or not to be tested. The balance of that may change if we have treatments that can slow disease or change disease course dramatically. The balance of how much you take away an individual's choice may change. But that is a fundamental of genetic counseling, that you want the individual to have free will to choose whether or not they have this HD, whether or not they want to know that they have the HD expansion. I don't know, in terms of moving treatments earlier, Phyllis at Iowa has done this terrific work based on studies with kids with HD, looking at the CAG expansion and contribution to cognitive development and intelligence. So it may be particularly thinking about the ASOs, the drugs that suppress Huntington protein production, like the Roche compound. It may be that we would not give those extremely early in life because it could impact cognitive development. That is what some of Peg's research suggests. Right. So I don't know that for at least those compounds that prenatal screening is not necessarily going to change how we would use them, but there are so many other treatments that we have that you may consider giving earlier in life.
Yeah.
So we did have a question come through, and I know Emily touched on this just a tad, but I'm HD negative and having a lot of survivor's guilt. Their dad and 3 siblings all tested HD positive. Do you have any advice or suggestions for him or her? Actually, I don't know if it's a him. It's a him or a her.
We'll assume a him. I definitely encourage him to find a therapist and connecting that therapist to the COE social worker So the social worker can communicate and educate them, again, providing an in-service with that therapist of what HD is. Joey and I recently did this with a couple of therapists in the local area, and they have been extremely receptive to receiving information from us. And I think being an individual going through that survivor's guilt, you need to be working with someone who understands what Huntington's disease is, because a typical therapist, it's not their fault. Huntington's disease is a very rare disease. So connecting with a therapist, connecting that therapist to the COE, finding outlets like the HD Game Over, going to educational events, volunteering, doing advocacy events is so important because we have an amazing community. Our HD community is amazing. So embracing that, meeting people, participating in the mentor-mentee program offered by NYA, participating in the retreats. Just because you're negative doesn't mean you're not a part of our community. You are absolutely a part of our community. So embracing those opportunities that are available.
And we absolutely need people who are gene negative in the observational studies. We use them as controls because they've grown up in the same environment as people from HD families who do have the expansion. So absolutely, you can contribute to the science and to moving the drug development forward, which for some people is a very satisfying and rewarding thing to be able to do. And I think also recognizing that, yes, now you don't have the burden of facing HD in your own future, but it may give you the burden of caring for everyone else in the family, right? So if you have a father and 3 sibs who are all gene positive, suddenly you become the caregiver by default for everyone else, and recognizing what that burden means and who's going to support you if that's going to be part of your future.
And that's the hopes with genetic counseling, going through a COE or HD genetics, that you're working with professionals who know what HD is. So hopefully you've had those conversations of what is this going to look like if I test positive? What is this going to look like if I test negative? It's not going to be perfect and it may not turn out the way you think, but at least you've processed that information.
Yeah. So I tested negative. And so hearing this comment seeing this comment coming from online, I can relate to, but there is a lot of power in continuing to tell your story, the way you were brought up, the way that you take care of somebody, the way that HD impacts you. And there's so many different platforms to do that on, whether it be social media, whether it be with Help for HD, whether it be literally just talking to people who don't know what HD is and spreading awareness. There's a lot of empowerment in there. And for me, therapy is amazing. But sometimes I'm like, but do you really get it? Like, did you test negative for HD? So then you can't really relate to that therapist, though you can get a lot from therapy. You also want to try and reach the people who have like minds that are going through the same pain that you are. A little plug for Instagram, and she's probably everywhere else, like TikTok and stuff, but You, Me, and HD with Charlie. She is a very great advocate and voice online. She said it, she tested negative, but she's very good at the whole, I am still impacted by HD. I am still part of this community. I am still important. I follow her. You will see a lot of great videos.
Yeah. I think that we can probably end on that. We're ending a couple minutes early, but all of our next speakers are geared up and ready to go. Thank you guys so much for coming on with us and doing HIPE 2023.